This one said, I was recently given the responsibility of coding wound care. I've never coded wound care and have to say I'm lost. The physician documents one thing in the body of the note, and the diagnosis codes most often do not match the documentation. The diagnosis codes are the original presenting problem. Do you have to carry that? Do you have to carry the diagnosis throughout the care and add the new diagnosis as the wound ulcer heals or gets worse, or do you just use the current diagnosis? Wow. I was really excited to see this come through because, as I mentioned before, I love diagnosis coding. It is so much fun because it's all about the disease process and stuff. But of course, I found another little comic. What this one says, well, we took care of that ulcer on your heel and the one on your bottom. I don't think you'll have any problems anymore. And you notice he's just ahead. And then the nurses are over there saying, I don't think I'd tell him about the ulcer on the back of his head. Anyway, I thought that was great. So yes, it is a problem, especially with wound care. Oh, it looks like the font. Oh, there it is. Okay, thought it cut off. A couple things that I wanted to mention. This gives me an opportunity to do like a little teaching moment on something besides just the diagnosis codes. So I didn't go off and find a bunch of diagnosis codes for you to be aware of because that's really not the question. The question is, how come I have a disconnect between what the provider's doing at the wound care clinic, a lot of times it's a wound care clinic or a wound care doc, compared to what they came in for or what the referral was for, etc. So why do we have this disconnect? And isn't it important that we've got the right diagnosis? A lot of times everybody thinks, well, it's more about the CPT code in outpatient. And it is. However, I mean, the CPT code is how we get paid, but you hear me say again and again, we code for statistical purposes. It just happens to be a convenient way to get paid. So one, we want to get the statistic right. We want to know how many ulcers or whatever we're getting in a given amount of time, how many diabetic ulcers versus other type of ulcers or wounds. And then we also want to make sure that we're coding for medical necessity. And the reason that is so important is that we have these things called LCDs and NCDs. When you have a Medicare patient, and Medicare is your largest payer out there, whatever Medicare does, just about everybody else ends up doing eventually. So Medicare works off of these local coverage determination, and the NCDs is national coverage determinations. Ultimately, what it means is they look at a diagnosis, okay, a disease, let's say a diabetic foot ulcer, and then they determine what treatments are the most effective and cost effective to fix that particular diagnosis. So that's what they'll cover. Okay, so if a new treatment comes out, it may not be covered. It may be a great treatment. However, if it hasn't gone through the LCD or the NCD, Medicare or the insurance company may say, well, yeah, it may be great, but we're not going to pay for it because it hasn't been proven or it's not cost effective to do this at this time. We have to do more research. So in the event, what that does is Medicare Part D may say no, and it's not based on medical necessity. So if you want to have it done, you're going to have to pay out of pocket. Now, for the most part, Medicare runs these. However, again, whatever Medicare does, usually the other providers follow, not providers, but the payers follow. But we remember medical necessity is the key. Is it medically necessary that this new treatment be used like hyperbaric chamber when we could just do a skin graft and let it heal slower, right?
Apparently, it's
Because that's
Part B, not Part D. Jennifer
Oh,
saying.
okay. That actually came from, that's linked. So you guys, I copied that from an article. So the link is there in the footnote, and
Got it.
and we know Jennifer's right because Jennifer is a billing expert. Okay, so when they establish these policies for the particular item. It could be an illness or an injury, and they'll say this is covered, but this is not. Okay. And also, LCDs could change for different areas. So let's say we're talking about Texas, where I'm at, versus Boston. I always like to give Boston as we probably have more diabetics, I'm just assuming, because of our nationalities that are living in Texas compared to the Upper East Coast, right? Uh, uh, People with a Hispanic background are predisposed, and certain other ethnicities are predisposed to certain diagnoses. It's just part of the disease process. And so we have more of that ethnicity in our part of Texas. So maybe for their LCD, these specific treatments are approved, but they may not be approved in another area, like Jennifer's up by DC may not be approved there, but it is in Texas. Okay, so that's important to remember. So if you're a coder and you're working remote, okay, then you have to be aware that LCDs could be different. You may have a provider in one area that's these procedures can get paid for, and another one that's not. Also, again, it's not all about Medicare, just Medicare, but I said that's like the third time I tell you they're the biggest payer. Why does it matter, though? Actually, when you boil it all down, we need the diagnosis, make sure it's the right diagnosis to show medical necessity. So if the auditor is looking at the documentation and the coding, they're looking for medical necessity, and the diagnosis code gives us that. We definitely want to make sure that our patient fills out an ABN if they aren't going to, if it's something that's not going to be covered under an LCD, or your provider will be picking up the cost most likely to do the procedures. Now, I've got some great examples that I wanted to share with you to just kind of bring it down to practical things that you might see in a wound care clinic. And the number one thing is ulcers. So this first example is wound care diagnosis and treatment. So if a patient's discharged from the hospital with COPD, diabetes, peripheral vascular disease, neuropathy, and a foot ulcer, and is referred to Dr. Ichitozi, I came up with that, his wound care clinic. Now, what diagnosis is going to be the one that got the referral to the wound care clinic? It's not COPD, it's not diabetes, it's not the PVD, it's not the neuropathy, it's the foot ulcer. Now, the foot ulcer is the wound. That's what the patient's being seen for. Now, it's a diabetic foot ulcer. Is it important to document that in addition the patient has diabetic neuropathy, not diabetic heart, PVD, and they have COPD, so they don't have good oxygenation probably? All of that's important. But if you put that the patient's being seen because they have diabetes, that's incorrect. The medical necessity for a wound care clinic is not diabetes. It is not COPD or neuropathy or PVD. It's the foot ulcer, a diabetic foot ulcer. Okay. Then, as the foot ulcer is, it's staged. So each time that the patient comes in to be seen and the stage is getting lower and lower because it's healing, then that has to be changed. The diagnosis is going to change as the patient gets better or could get worse. We could have a small, diabetic foot ulcer that they're trying to get ahead of that ultimately turns into gangrene. And then we have necrosis, death of a tissue, and we're amputating toes. Okay. And then we're not treating a foot ulcer, we're treating gangrene. Correct? So again, pay attention to the documentation, and if we have to educate or update, then we need to make sure we've got that documentation correctly, or you will not get paid in the wound care clinic. Let's give another one. Patient released from ER due to brown recluse spider bite on the left arm. Now, again, spider bites, please, guys, they're not, in snake bites, they're not as bad as everybody thinks. It's not like in the movies. However, you don't even really get antivenom anymore. But they can go bad very quickly, and especially if you have comorbidities. So this is really, really bad. This is a spider bite. We got a brown recluse. It's 9 days after the bite is what the picture says. Now, ultimately, brown recluse, what it does is it softens the tissue so that they can eat whatever, and suck out the juices of their victim. And so it's like a necrosis that builds up. Now, this is not actually an ulcer. This is a wound, a gaping wound, and it probably is going to end up getting a graft. Again, how do they treat these? Usually, you can go and read, but they usually just treat the signs and symptoms. Actually, a black widow is much better to get a bite from a black widow because it doesn't get necrotic like that. It's actually works on the nervous system. It's very, very painful. But people that have bad immune systems or have other types of conditions that are already affecting the nervous system, like diabetes, it could be really, really bad. I'd rather get bit by a black widow than a brown recluse. So this just real quickly shows you one is a neurotoxin and one's a cytotoxin in the venom. So two separate things. So the treatment would be different for each one. Okay. Now, why is the patient being seen? They're being seen in the wound care clinic for a wound. The spider bite is the external cause, right? It is a wound, the type of wound, and it'll be measured, the depth, and so on and so forth. So we want to make sure we get the diagnosis codes up to date each time. And then we have to check the LCDs to make sure they're covered. The treatment's covered. So again, I just had a couple more pictures and things to explain why it's important to code to the highest specificity and get those diagnosis codes right. And also, LCDs are changing constantly. You may have to check like 6 times in a year. So whoever's in charge of that, especially if you're in a wound care clinic, you need somebody that's in charge of checking what's going to be paid for. This is actually a brown recluse, and it's a graft. You can't quite see it very well, but it's 38 days after the bite, and that's actually been grafted in. It looks like cheesecloth in there. So another thing that they do is this HBOT. I got to do a tour of a wound care extension of the hospital, and they have a oxygen hyperbaric treatment. And this is something you'll see as a treatment that may or may not be covered in a wound care clinic. Nowadays, I think you're seeing more. The place that in San Angelo, I think they had 2 chambers or 3 chambers at the time we toured, and they probably have more now because it's very, very effective at healing quickly. Ultimately, what it is you're not putting oxygen in the bloodstream because if you're breathing it, that you're in a chamber, just like if you were to get the bins, a diver's in, and they infuse the tissue itself with oxygen, which allows it to heal faster. They not only use it for now certain spider bites, but certain wounds it's very effective on, and other things it's not. So medical necessity is very, very important. If you don't let them know what the origin of the wound is, oh, this guy's got a giant wound on his leg. Well, it's because it's a brown recluse spider bite, and it was not cytotoxin, so we know that would be beneficial to put them in a hyperbaric chamber versus a black widow, which wouldn't be because it's a neurotoxin, and oxygen is not going to affect the nerves. It doesn't affect, you want the tissue itself. And again, I'm kind of paraphrasing and guessing at that because I'm not an expert in that. So take that with a grain of salt, which one you do and which one you don't. They are studying brain injuries now. That was that I linked that. But the thing about these HBOTs is it's painless, it's invisible, it's simple to do. And once you've paid for the machine itself, it's pretty cost effective. These are actually approved by Medicare. That means the LCDs, the NCDs are paying for it because it's cost effective. If you show medical necessity, which would be a diabetic foot wound, and sometimes burns will, again, we're infusing oxygen. And now they're studying for brain injuries and stuff for veterans that have had brain traumas. And it's looks like it's going to be very, very promising for them to be able to do that. This is what one looks like in a clinic. You can't have any makeup on. You have to like strip down and put on a gown because you can't have certain metals and stuff like that. Again, and it's a tube full of oxygen, intense oxygen that's pressurized, pushed into the skin. And so that's exactly what it looks like. They plug you in and you're not in, and it's not fast. You're in there for a couple hours, I think is the way it works. I've known one person personally that's done that to a wound on her ankle. So great stuff, very exciting. And I'm glad you're doing wound care. I thought it was pretty interesting, but it is a different type of coding because of these LCDs and stuff that you have to be on top of it constantly. Documentation is usually not the best that it can be because they're just taking stuff from discharge summaries and not getting the right code associated with the CPT code. And therefore, you'll have people, not only do you have wound care nurses and providers, but you have wound care coders. And so they're separate and sometimes do it exclusively because you got to stay on top of it or you don't get paid.
Over in YouTube, Susan asks, where do you check the LCDs?
Well, Jennifer can tell you because that's something that she has to deal with all the time. I
I'll
would
be
just,
happy to.
yeah, let her explain that. She's much better at that than I am.
Well, the reason I had to interject is if anybody knows the structure of Medicare, Medicare Part A is hospital and rehab. Medicare Part B is physician. Medicare Part D, as in David, is your pharmacy
Drugs.
prescription.
Yeah,
So
isn't that
that's yeah. So that wouldn't have anything to do with your wound care. So
weird? I wonder why that was in that article.
they just typo probably didn't catch it. Yeah. The LCDs and the NCDs, if you go to your local MAC carrier, so in my area we're Novitas Solutions, so I would plug in that website. You go to, they have, like ours, Novitas, you have a little sidebar that says LCD and NCD, and you click on that, you can plug in 29889 CPT code, and it will tell you if there is, you could plug in wound care and it will pull up all the NCDs, or it will do NCDs and LCDs. Because like Alicia said, you know, if you're a Wisconsin physician, your LCD might be totally different than mine, but a national coverage determination is nationwide, and every Medicare contractor will follow that one. But you could have different local ones depending on, you know, people in Florida have a whole lot more Medicare policies than somebody in Alaska possibly, or Montana. You know, there may not be as many Medicare patients available in that area with particular problems. So yeah.
It's exciting stuff. And you got to be on top of it. How often do you suggest they check them? I mean, if somebody's doing that, they got to, the thing had said like 4 to 6 times is what I heard.
They can adjust them. Right now, they are actually going through a big adjustment because they are transferring all the, because you know, you can go on there and it will say they need to have these medically, it is paid for these medically reasonable diagnoses. This is, you know, you need to do step A, B, C, and D before we're going to allow this, or you get 12 per year, or things like that is what they'll say in these LCDs and NCDs. But then it also gives you the updated. So if you, but however, you don't have to constantly go in and check as long as you belong to your MAC carrier's listserv, because when they change, they send it out in the part of the listserv email, and those go out 2 or 3 times a week. So as to any changes that have been made will be published in their listserv. They don't just willy-nilly do it because they feel like it. They let everybody know that there's been changes. So
yeah.
So do the physicians look at LCDs?
They probably wouldn't even, they probably think it's a certain drug or something and wouldn't know what you're talking about.
Yeah, because it looks like NDCs. That's your drug. No, that's honestly, that is your clinic manager, your coders, and so that's their responsibility. That's part of what you're being paid for. Now, don't freak out if you're going through your schooling and educating, you're thinking, wait a minute, I don't remember anybody talking about this. This is something that's real world, and it's just part of the policies and procedures in an office. Okay, it's not like you have to learn anything new. You're learning the codes, and then you just look, oh, nope, that code can't be used with that diagnosis. It's that simple. You know, That's
Yeah.
it's a little
And
technical.
they're
That, but it's
particular
pretty much
for the field that you're in too.
right.
I don't know all the LCDs and NCDs. I only knew orthopedic ones. So
Right.
whatever is going to be relevant to whatever field you're in. So
Yeah, and if you're in risk adjustment, you don't care because you don't look at CP diagnosis code, or you only look at diagnosis codes and things like that. So, yeah, it's
yeah.
just a background thing that we do.
Do you need more medical certification and business training? Learn more at www.cco.us.